if you guys recall, right, I said something last time we did musculoskeletal lectures. I said cells, right? And that a good analogy to use pretty much for all cells. I said cells are bags of potassium and sea of sodium, right? So what does that mean to you? You want to answer? What does that mean? Cells are bags of potassium and a sea of sodium. Anyone can answer that question?
Well, they're two separate ions. I mean, they're both positive, but they're being separated by a cell membrane.
By cell membrane, yeah. So what essentially Ian is saying is correct, right? So cells are bags of potassium, so it means potassium is predominantly found inside the cells. They're found in the sea of sodium, so sodium envelops the surrounding environment, right? There's a lot of sodium. And if we look at the concentrations, right? First of all, let's look at the concentrations. So extracellular environments outside the cell, intracellular environments inside the cell. So inside and outside. So outside the cell, the concentration of sodium is 145 millimolar. But if you look inside the cell, right, it's 15 millimolar, right? Millimolar refers to, the first part is, it's SI units or System International. Larry means how many moles per liter of fluid. So if I took your blood sample and I were to analyze how much of solute particles there is, right? Once you start doing your clinical rotations, you often will see nurses draw blood. It's sent to the lab, and then doctors will look at the result to then see, right, what type of abnormalities the patient may have, right? So blood work, right? So if I check your blood, what I found is outside the cells, the sodium level is 145. Inside your cells, the sodium level is 15. So the gradient is there. And this is here, you see, right? The sodium is found more outside than inside. But now let's look at the potassium, right? So if I check your blood, the potassium in your blood and your plasma, right, will be 4.5 millimolar. But inside your cells, right, they're 120 millimolar. Sometimes if any of you do interfacility transport on a EM, or you go for emergency calls to nursing homes, have you ever been called for labs? So you go there, they tell you code 1, abnormal labs, right? You come in and you're like, what's going on? They're like, yeah, this person needs to go to the hospital. So usually what happens in nursing facilities, when they take the blood sample, they may shake it around and they break a lot of those cells, and the contents gets released. So a lot of this potassium, right, that's inside the cells gets released. And now all of a sudden, instead of having extracellular normal level 4.5, let's say it's like, 40, right? So, and now it distorts the normal internal versus external environments. So they will send the patient to the hospital for abnormal labs because, they want to make sure what else is going on. But usually that's what happens. They call it hemolysis of the cells.
Right? What would the treatment for that be?
What the treatment would that be? So most likely, if a patient had of 40 millimolar in their blood, they'll be dead. So just by looking at the labs, I can say that if the patient's still alive, those levels, they shook the blood tube so hard or during transport to the lab that it just cells hemolyzed. So you have inappropriate extracellular concentrations. So for you to transport them, and in a couple of hours, they will send them back to the nursing home once they do their own labs, right? So there's no real treatment per se. Answer your question?
Hey, Nick, is this hyperkalemia, and is this what causes the arrhythmias?
It can. We're going to talk about that specifically when we do the cardiac chapter, and I'll outline it more specifically. But for now, what we want to concentrate on, right, is the gradient. We want to say that outside the cells, we see a lot of sodium. Inside the cells, a lot of potassium, and the gradient is maintained, right, why is the gradient maintained is in the cells, right? We have these sodium potassium ATPases, right? Sodium potassium ATPases. They use ATP, and their primary job is throw out three cations and bring, right, from whatever potassium was outside, bring 2 potassium in. So they're working, right? And they probably, to be quite honest with you, they're probably using 20 to 25% of ATP stores in your body to do this. A lot of cells have this sodium potassium ATPases, and they function to basically restore that gradient. They throw out 3 sodium ions back to the extracellular fluid, and they bring 2 potassium ions inside. Right. So this was we talked about the concentrations, right, of those ions. But then there's another important factor. Let's talk about the equilibrium potential. So equilibrium potential we see here, right? What is, so we notice, right, for the sodium, the equilibrium potential is 66. Sorry. But for the potassium, the equilibrium potential is negative 88 millivolts, right? Millivolts. How is that measured? So if I bring a voltmeter, right, a unit that measures volts, and I measure the potential across the cells, when equilibrium potential is read, meaning the channel that's gating that specific ion is opened, at what point I reach equilibrium on both sides. So for the sodium, I reach it at plus 61, but for the potassium, I reach it at negative 8. The reason why I'm focusing on these two is because these two cations, right, sodium and potassium, they are the ones that they are primarily responsible for the signal propagation, right? We have 2 tissues in them that have potential of being they have the potential to be excited and propagate the electrical signal. So anyone knows what are the 2 tissues that have the potential to repolarize?
Cardiac's one, right?
Cardiac is one, but overall, how would you name the tissue? Where cardiac cells fall under? What type of tissue is it?
Involuntary.
So what I mean, is it bone? Is it skin? Is it muscle?
Smooth.
So it's muscle, right? It's not smooth, right? It's striated. So we have one type of tissue can perform action potentials is muscle tissue, which could be skeletal muscle, could be cardiac muscle. What is the another type of tissue that can perform action potentials?
Nervous tissue.
Nervous tissue, right? Very good. So the what you guys want in your notes, the 2 tissues that are able to perform, right, action potentials is nervous tissue and muscle tissue. Muscle tissue being skeletal muscles, cardiac muscles, and the 2 predominant ions that are responsible for that is sodium and potassium, right? And we're going to see how it does it in more detail right now, how it propagates that signal. And it's going to employ both the intracellular and extracellular concentrations, right, that we see here, and also this equilibrium potential, right? So this is what I'm going to focus on, right, in terms of propagation and differs. And I'm going to use an example here. Let's say we have a neuron. I'm going to draw. And we're going to say this is a sensory neuron. So you make it a little bit bigger. So before we talked about right, how it propagates, but imagine this is a sensory neuron. And then sensory neuron, let me just use an example of, so somebody comes in and has touch on my finger, right? So the touch that you are applying, or the touch that's being performed, it's performed on the mechanoreceptors. So we have mechanoreceptors, in our neuron. And these are not voltage gated. These are sodium leaky channels. So this is sodium leaky channels. They are not voltage gated, and I want to draw this specific distinction. So when you apply some touch, right, the sodium from the outside that we said is found outside, right, cells potassium in a sea of sodium. Some sodium can trickle in. Depends on how much stimulus you apply. Now, I'm going to basically make a schematic at the bottom of the other picture, right? We're going to say at this point, this will be our threshold potential at minus 50 millivolts. At the very bottom here, we're going to say this is our resting membrane potential right now here, and it's negative all around this neuron. And it's about negative 70 millivolts. Now, usually the cells themselves, they have potassium leaky channels. So these will be potassium leaky channels. That secrete potassium outside the cells, right, are coming out. And we know that the normal, right, electrochemical state for the potassium, or equilibrium state, I should say, right, we see that it's negative 88 millivolts here, right, so for the potassium. So here, we're going to say at the bottom, we'll make another one. We're going to say the equilibrium potential for potassium. And let's say, even though it's here, the level is negative 88, we'll write it negative 88 millivolts. So as you see, the resting membrane potential is much, much closer to the potassium potential. And that's when these channels are open, right? The to leak out, because we said that cells have a lot of potassium in, and the surrounding doesn't have a lot of potassium. So the potassium wants to leak out. So it wants to reach the equilibrium potential. Now, if we look at the equilibrium potential of sodium, let me take, right? Equilibrium potential for sodium, what is it? It's plus 61 millivolts. So we'll make another thing here. I'm going to say plus 61. This is equilibrium potential for sodium. Right? So this is what we got. So let's see how that signal propagates. So right now we are right here, we're at the resting membrane potential, right? And let's say you give me a little bit of a touch and a few sodium come in. And let me just make these gradations so you see, right? So this is negative 88. This is minus, let's say, 80 here. This is minus 70. This is minus 60. This is minus 50. Let's say here we are going to be at 0. This is just 10. Say this is T. And here we have plus 61 to the sodium. So let's say you touch my finger, and a few sodium came in, right? And they took the resting state of the membrane, they make it slightly positive. But you went to, and it's created this type of impulse, right? You see that. Has it reached my threshold potential at minus 50 millivolts?
No.
No. So the impulse was not strong enough, right? Impulse was not strong enough. Let's say you touch me a little bit, stronger next time, and the impulse is now becomes like that, right? Has it reached my threshold?
No, sir.
No.
Not yet. So we call all these, right, sub-threshold stimulus. So they will not initiate the threshold. So what's so special about the threshold? So the threshold potential, I'm gonna here, right? We have specific sodium gated channels. So they have gates, right? So this is activation gate, and this is inactivation gate. So these gates are covered unless you trigger the threshold potential. No sodium can come in. So no sodium can come inside of them, trigger this threshold potential. So now, let's say now you stimulate my finger really hard, right? You tap on my hand, and that stimulus was strong enough for me to sense it. So now we're going to say that I'm going to remove these. Your stimulus was strong enough to reach threshold. So what happens at this stage? At this stage, right, your sodium gated channels, right? Sodium gated channels will activate. So what you will see happen, we will see that the activation gate open up, right? And we're going to say occurring, right? This is an activation gate trying to close at the same time. What's important, sodium is now coming in, right? And there's a lot, there's thousands of these channels that are found on the cell membrane. And the moment you trigger the threshold, your activation gate is open, right? And activation gate starts to close. But this action allows all the sodium that's found outside to rush in. And we know that outside of the cell, sodium is in 145 millimolar, and inside is only 15 millimolar. So sodium, based on its gradient, right, through the fusion and through these channels, starts to rush in inside. And that's why we see this positive upstroke, right, that's coming out. And it's rising. Why is it rising? Because the moment those channels are open, the goal of the sodium is to reach its equilibrium potential at 60 plus 61 millivolts. It's going to try to get to that 61 because that's what it wants to do. However, right before it reaches plus 61, right? We see this here. What happens is the sodium channels, the activation gate remains open, the inactivation gate shuts. So inactivation gate shuts, activation gate still open, but can the sodium ion come in now? Can more of them come in? No, they cannot, right? They cannot come in because the inactivation gate shuts. At the same time, when this occurs at this point here, what you see is you also have voltage-gated potassium channels on the cell membrane, right? So these are K plus voltage-gated. So this, what happens is we'll have a potassium channel that now activation. This is the inactivation gate. So what happens at this time, a lot of potassium from inside the cells start rushing out, because we know cells are bags of potassium in the cell. So as the potassium is rushing out of the cell, it's now taking this positive charge of the membrane and it starts to lower it. It's lowering. Why is it lowering? So if we look here, we said inside the cell, right? Potassium is high, it's 120. Outside the cell, it's lower. So it's going through the concentration gradient. But another thing, it wants to reach its equilibrium potential at minus 88, right? So we see minus 88. So it starts going down here. But before it reaches minus 88, we have the same phenomenon occurring, right? The inactivation gate gets closed. But no more potassium can depart, can leave the. So we see it stop here, right? And the membrane goes back to resting state. And we say the membrane has went from depolarization state to repolarization state. Let me use a different color. Right? So here it was depolarizing, and here it repolarized. Right? And then went back to its resting state. So the primary cation that was responsible for polarization state was sodium. And the primary cation that was responsible for the repulsion was potassium. How does this occur? This occurs with, first of all, influx of sodium, and then we have the efflux of potassium. And this, right, this whole sequence that you see here, it goes from patch to patch. So imagine we have multiple patches like this on the neuron. This is our peripheral side, and this is going to, we're going to say this is the cell body, right? And it's going to our central nervous system, which I will draw here. Right? So it propagates patch 1, 2, 3, 4, 5, 6, 7, 8, 9. It goes like this, patch to patch. So what we actually see, if we look at the membrane, as membrane 2 starts its depolarization cycle, this membrane is repolarizing, right? And how does occur? Because this propagation of this signaling is spreading, right? This signal is spreading on the surface. So it's spreading on the surface. It's going from patch to patch, depolarizing slowly, right? Each cell. So as patch 2 is going depolarization, cell 1 is going repolarization, and so forth. And it continues all the way down until it reaches the central nervous system, where the impulses will be interpreted, right? How does it do it? It does it via exchange of these ions, right? And they want to reach their equilibrium potential, but before they do so, right, they stop and other channels open. Now, let me ask you this question, right? Let's say instead of me just touching your finger like this, right, to stimulate above threshold so you feel it. Let's say I take a hammer, right? I take a hammer and I hit your hand very, very hard, right? So my question is, do you suppose your action potential becomes like this? Very exact. What do you guys think?
I would think it does, or well, I would think the initial model you showed us where it depolarizes first and repolarizes happens at a faster rate rather than a higher spike, if that makes sense.
So would you say so you say it happens at a faster rate versus a higher spike?
Yes.
So let me see if I can draw it right. So what you're saying, instead of what I drew before, let me take a different color. What you're saying, it does this. So we have number 1 and we have number 2, right? So you think it's number 1?
Yeah.
Okay. Does anyone have alternate
Yeah.
answers? Yes.
I would assume it would be a combination of both, where you'd get the initial reaction from like the pain spike, and then as the bruising and the damage starts to spread out a little bit, that's when you get like slower, if that makes sense.
Yeah. So to answer your question, number 2 is incorrect, right? And when you have stronger stimulus, the frequency of it increases. The amount of depolarization remains the same because the equilibrium potentials cannot be exceeded from too much from this. Right? So in terms of stronger stimulus will not cause these of spikes number 2. What it will do is it will do number 1. So the frequency of them will intensify, right, until the stimulus is relieved. So once the stimulus is relieved, then the frequency will diminish, and then they will become lower like this, right?
So with higher force, does it go past the threshold, or?
Yeah, the higher force will trigger the threshold, but the frequency of the impulses will be increased. So they may even be faster than this, right? Like that. So you're feeling that effect, but they will not, and they will not be this number 2, right? Because you cannot exceed your inherent values for equilibrium potential for these.
So if I'm understanding this correctly, right? A greater response, it increases the frequency. It doesn't increase the
amplitude. That is correct.
Okay.
Right, as I showed you, but the amplitude remains consistent, right? But I want to say, here we're learning about the neurophysiology and the for the neurocells. For the cardiac cells, we're going to learn about the cardiac chapter. They have different voltage. So in terms of the gradient, it might be a little bit higher or lower. It will not be much different from what you see here. But yes, there is some distinctions from cardiac tissue or muscle tissue versus neural tissue, right? But overall, if the intensity of the impulse increases, we see higher frequency, as opposed to we do not see increased amplitude, right? So the next thing that first of all, let me ask you: is there any question in terms of the major one and how this all happens in terms of what I drew so far?
Yeah, I just wanted to clarify.
Yeah.
The membrane voltage of the nerve at rest is minus 60, right?
Some books will have this, but let's say we use the slides that we have here, right? It could be negative 60 to some books will say negative 90. I choose a number, just say negative 70. So negative 70 was just a number that I employed. But yes, we'll give you slightly different numbers. What you want to, the major part that I want to say is there is going to be a resting membrane state, right? Which here I'm using negative 70, and there's different state, which is going to be threshold,
right?
Which will be a little bit more towards the positive side. So here I used negative 50 millivolts, and all this is essentially, the reason why I use this is I'm employing, for example, if you see in this diagram, it was from another book, we see that this say they use negative 70, right? They use negative 60 as a threshold, but that number, it doesn't matter, right? As I use negative 50. Once the most important thing that I wanted to get to you guys, once the threshold is reached, it's like all or none phenomenon. The moment you have enough stimulus to reach the threshold, all sodium channels open, like one or two open, all of them open, so that the sodium can rush in. When the sodium rush in, we see this depolarization wave sweep across the membrane. So what happens is, so this was negative, sodium is coming in, all this membrane is becoming positive. This impulse is sweeping across, right? These patches like this, going from patch to patch, depolarizing the membrane. And as this membrane is depolarizing, this membrane starts to repolarize, right? Starts to repolarize means potassium is leaving sodium that was coming in. So as the potassium is leaving, we start this process of repolarization because we want to return the membrane back to its normal resting state so that this can occur, right? The other concepts that's very, very important, and it will be crucially important when you're going to learn about cardiology and EKGs, is we have these concepts of absolute refractory period and relative refractory period. So absolute refractory period means there's nothing I can do. Even if I take, two hammers and I hit your hand, right? If that tissue is refractory period, it will not send another signal. But the moment it's in the relative refractory period, right, it still had not reached, right, the next phase of the next impulse. Here, at the relative refractory period, here up until this point, if enough stimulus, you could again cause depolarization to occur, right? So relative refractory period, if I apply a strong enough stimuli, I can cause again the cell propagation. In the absolute refractory period, nothing I can do, right? And why is this? Why is this? And I'll explain to you why is this. So here, remember, using an example of these sodium gated channels. We said on the rest, right? We said the activation gate is closed and an activation gate is open. This is an activation gate. The moment you reach threshold, what happens? Your activation gate opens and an activation gate starts to close, right? This is the upstroke that you see. At this portion here, right? What we see is, we see activation gate is still open, but the inactivation gate gets locked, right? for you to be able to trigger the next impulse, the sodium channels must return to this configuration. It must return to the resting state configuration. It must return to this configuration where the activation gate is closed and an activation gate is open. Only then can it trigger. But if it remains in this configuration, no sodium can entrain. No sodium can come in because an activation gate remains closed. So we got to get back to this original resting status of the sodium channel to be triggered again, right? An activation gate, this was resting. This was active. This was inactive. And this was resting. Okay, does that make sense?
Yes, sir.
Okay, so very good. Is essentially the chart. Now, you on the next question, right? So we talked about the myelin sheath. We talked about Schwann cells versus oligodendrocyte. So what is that, right? So imagine I take special kind of. I'm gonna say this is the right. I take an iron. Right. I'm gonna say this is the handle of an iron. Plugs into the outlet. I iron out the cell. I make it flat, right? Cell is flat. This is the nucleus. And what I do is I take the cell, right? Take the cell, and we're going to say this was my neuron. I take the cell and I wrap it around like this. Around it, right? So I take an iron, I make the cell flat, I wrap it around the neuron, and I make these revolutions around it, right? And I have this thing wrapping around multiple areas of the neuron. Right? So it's wrapping around the neuron, creating these sheaths, if you will, right? So the sheath from sphingomyelin, it's a type of fat. Now, do you guys think fat impulses good or bad?
Bad.
Bad,
Bad.
right? The fat is an insulator. The fat is an insulator. It does not conduct impulses well, right? So before we saw propagation of the right impulse, it was from patch to patch like this. It went patch to patch. But what happens in this case? Can the impulse move out of here? No, it cannot. So the way the propagation way works, it goes like this, right? It moves from node to node, and it depolarizes every node. These gaps here I call Ranvier. Here we actually have all these sodium channels, potassium channels, right, that are voltage gated. But and the impulse can, right, sodium can come in, potassium can come out. The impulse then propagates inside, right? No leakage is occurring because this membrane will not allow any leaks. And again, when it reaches the nodes of Ranvier, then where you have the exchange again, and then this will go. This whole conduction is called saltatory conduction. Saltatory conduction means conduction from one node of Ranvier to another node of Ranvier, right? So we call it saltatory conductions. It's node conduction as opposed to patch conduction, or it's propagating here, right? Let me make it a bit smaller, right? So this is unmyelinated neuron. Unmyelinated neuron has conduction that's slower, patch to patch. In myelinated neuron, what we see is we have conduction from node to node that's occurring like this. Now, let me ask you something else, right? So let me add a page here. All right. So suppose I'm going to draw a couple of neurons what I'm gonna do is took this neuron, right here. I made a cross section. I cut it like this, right? And I wanna put it here. So we're gonna say this is neuron number 1. This is neuron number 2. I'm gonna say this is neuron number 3. Here, I'm gonna take this is gonna be the Schwann cell, and this Schwann cell is like this, right? On this Schwann cell is like this, and on this neuron there is no Schwann cell like this. Out of these number 1, 2, and 3, which one would you say is myelinated and which isn't? So these are 3 neurons.
3
right?
is myelinated.
You say 3's. Aaron says 3 is myelinated. What about 1 and 2?
Two is myelinated, but maybe 1 is not.
So 2. So it says 2. You say 2, but number 1 is not. Anyone else have any alternate answers?
I'm just going to be different and say all 3 are myelinated.
All 3. Yeah. All 3. Any other? Any fourth options?
None of them.
No, Ian says none of them. So to answer the question, so number 3 is myelinated because we have, or if it was central nervous system, it would be oligodendrocytes around the neuron forming multi layers. Number 2 is not myelinated because the myelin is not forming complete surrounding of the neuron. And number 1 is diseased. Number 1 we see in the disease states, right, such as multiple sclerosis or Guillain-Barré syndrome. So number 1 is diseased. So usually, even if we have in our body unmyelinated neurons, they do have some form of cells or oligodendrocytes around them, but they're not making full revolutions. So is everything. Number 1 is diseases, right, like multiple sclerosis or Guillain-Barré, right, syndrome. It's unmyelinated, right? It's diseased. Here, this is your regular unmyelinated neurons. Why? Because it's not forming complete around the neuron, but you do have some cells, right, Schwann cells or oligodendrocytes around it. And number 3 is certainly myelinated because it has multiple revolutions around the neuron. All right. Hopefully that concept is very clear for you guys.
Question.
Yes.
So 2 is myelinated. It's just incomplete. Does that mean that it's damaged or?
It's not damaged. It's not damaged. In the normal anatomy of physiology, we call number 2 unmyelinated. Why is it not myelinated? Because this is not forming complete sheath around it, enveloping the membrane. Look, if I have sodium channels here, right? If I have sodium channels here, they can easily leak out and potassium can come in because it's not fully, right, surrounding the neuron, how you see here. You see how it's fully surrounding, isolating it? But
Yes,
in this setting, right, it doesn't make complete revolution around it. We see this opening here. And if we have this opening, right, for number 2, what happens is you have the exchange of the channels, right? So it's not going to isolate it. It doesn't fall that complete surrounding. Number 3.
It's not damaged. It's made to be that way.
That is correct.
Okay.
That is correct. It's not damaged. We have some neurons in the body that doesn't need fast conduction, and that's how it is. It's unmyelinated.
Okay.
Yep.
So there are 2 different diseases that are caused by unmyelinated or diseased axons, correct?
Yes.
Why do they present with different syndromes, and why are they different diseases versus just one?
So I have specific slides which will go much more in depth, but to answer your question briefly, right? Why does multiple sclerosis attack central nervous system versus Guillain-Barré attack the peripheral? Is because even though those cells have similar, the actual composition is different. So oligodendrocytes have a slightly different composition of the cells as opposed to Schwann cells. And the your body, your B cells, immune body cells that attack, they recognize the antibodies differently, right? So in multiple sclerosis, the reason why it only attacks the central nervous system, oligodendrocytes, is the compositions of those cells will differ from Schwann cells. But once I get to those slides, I'll show you more in depth. And yeah, for the most part, you will have muscle weakness, ataxia, right? And coordinated movement. So there will be some similarities. And what we worried about, right? If those muscles that innervate the respiratory system, once they get ascending paralysis to those muscles, person can die because they will have poor ability or inability to breathe. So we have to place them on a ventilator. Right? But basically, it's the body's immune system attacking different types of cells, bodies by the B cells, and oligodendrocytes different in composition than Schwann cells.
Thank you. Very good.
All right. So I think in terms of this, I think I have. Let me just make sure I did not skip any concepts for you guys, and we addressed all this. Oh, this concept that I was gonna explain, right? And I kind of touched it in the musculoskeletal chapter. But just imagine, right? Let's say this is your venous blood, and I check your potassium, right? And instead of it having 0.5 millivolts here, right? Let's say you have hyperkalemia. Let's say your potassium is 6.0, maybe 7.0, right? So the millimolar, right? So the concentration out in your cell, extracellular environment is higher than it normally is. Now, inside the cell, right, there's potassium. Outside the cell, there's less potassium. But if I increase the outside of the cell and I make it higher in potassium, right, do you think potassium wants to leak out as readily from outside the cell? Do you think the potassium wants to come out as easy? What do you think?
I think so.
So what I'm saying, let me just repeat the question. I check your blood, your normal blood volume for potassium, 5 millimolar. And now I have increased amount of potassium outside your cells. It's now 6 to 7. I'm just using arbitrary numbers. Now that the concentration gradient is higher, right? Usually the movement of ions is from high concentration to low concentration, but I now just increased that concentration. Do you think they want to move out at the same pace or slower?
Slower. They would want to go slower because the concentration's higher.
Excellent, right? Concentration is higher, they want to move out slower. And what happens is, yes, they want to move out slower. And what happens is, instead of having resting membrane potential at 70 millivolts like we have, because there's now excess of potassium channel, perhaps it now becomes, it raises the resting membrane to plus 60, or maybe it becomes, minus 60, or it may even become minus 58, right? So instead of being resting state here, let's say we have the new resting state that's here, right? So we're going to say because person has hyperkalemia, perhaps it's a dialysis patient, they missed their couple of appointments, right? They have excess of potassium in their blood. Potassium is now more, less potassium wants to leave from the cells. They have increased resting state, maybe minus 60, maybe minus 58. Now you notice it's now close to the threshold potential. So do you suppose this will make the cells more excitable or less excitable? Help me, if you want to speak, I cannot hear anything you're saying.
Less excitable.
Okay, now I hear you. Is correct. So it's a misconception, right? You are close to the threshold, yeah, you will activate it. But in reality, it's in this location, minus 60. What happens is, this what happens. Let me show you. So once this membrane reaches to minus 60 or minus 58, right, we said the resting state of the potassium was what? The resting status was activation gate was closed, right? And the inactivation gate was open. But when it reaches very near, right, this potential, what you actually see is this. This will close the inactivation gate, activation gate like that. So that level of potassium that's now is higher on your extracellular environment will essentially close this inactivation gate. And what do you think if this was coming to my muscle? Do you think my muscle is becoming more activated or it's becoming weaker?
Weaker.
Yeah, it's becoming weaker. That's why in the states of hyperkalemia, we see muscle weakness. Why do we see weakness? Is because by coming very close to the threshold potential, your voltage-gated sodium channels, right, inactivation gate becomes closed. You cannot cause depolarization to occur, so your muscles become weaker. And we see heavy muscle weakness in the state of hyperkalemia, right? In the cardiac chapter, we're going to learn that it can cause certain dysrhythmias, and we're going to definitely learn the treatment for it. You know, what do you give and how you would treat. By the way, we're not going to delve into it, but I was just curious to see, does anyone know what is the first drug you give in the setting of hyperkalemia?
It's probably sodium.
Sodium. So we could give it, but that's not the first drug we give.
We give calcium.
Give calcium. Helmi knows he's correct. Do you?
Couldn't understand that last question.
So let me re-ask the question. I said that in a setting of hyperkalemia, let's say it's 6 to 7 millimolar outside, which you notice it raises our resting state to maybe minus 60 or maybe minus 58. Because of that, this inactivation gate that's usually open in the resting state shuts. So we have these sodium channels that are now inactive. This causes the channels to not depolarize. So we have heavy muscle weakness, right, developing. In the setting of hyperkalemia, especially cardiac cells, they can cause dysrhythmias. And my question, what's the treatment for hyperkalemia? What do you give? Helmi answered calcium. And my question following that was, how does calcium work? How does it help? Calcium is the correct answer.
So is calcium the only thing you give?
Other stuff, but that's the first drug you give. In terms of priority and life-saving treatment, that's the #1 drug you give. So
would it change the voltage?
it will, but how? Do you know specifics?
Well, calcium has 2 positive charges, right?
Yes.
Well, let's see here. But where's the negative charge? I'm not seeing that.
Yeah. So only be the positive. So I'll tell you what, I will question for the cardiac chapter, right? And once we learn that, I will tell you specifically how this works, right? And you do have this drug in your protocols. You could give this drug for the setting of hyperkalemia, but in the cardiac chapter, we learned specifically how this will affect and why, why do you think I'm harping on a lot of these sodium channels, potassium channels, right? Is because once we start getting into heavy in-depth into pharmacology lessons, all these channels are going to come back in cardiac, in renal chapters, right? And we're going to learn about different receptor blockers, sodium, potassium, calcium, right? So this will become crucial in your understanding. So as we go step by step, right, as it's becoming a little bit more progressively involved or more complicated, you guys understand, these concepts. All right. This is the ion exchange factors. We talked about the sodium gated channels. We talked about potassium gated channels, resting status, right? Equilibrium potentials. Any questions about what I drew here? about the myelination states of the neurons. Let me make
I have
it.
a quick question.
Yeah.
So for people with muscle weakness,
Yeah.
so it's harder to depolarize and easy to repolarize?
Their channels if muscle weakness, let's say it's secondary to hyperkalemia, their channels, right? The sodium channels that let me redraw it again. Normally sodium channels when they're in the resting state, and this portion here, they should look like this. The activation gate should be closed and an activation gate should be open. Because it's the moment it depolarized, this is what's going to happen. That will open, right? And activation starts to close. This is normal. But in the setting of hyperkalemia, right? The resting status, we said activation gate was closed, but hyperkalemia would also close, then it will basically shut it. It will. So if your sodium channel remains closed, very little depol is occurring. And if you cannot depolarize the cell, no impulse can propagate, right? You cannot have actin-myosin interaction. So you will have heavy muscle weakness. So that mechanism of the occurrence is basically taking these sodium channels and making them inactive.
Gotcha. Thank you.
Yeah.